I will request Professor Surjit Singh sir to please come on to the stage.
Good evening. So we start this session. This is on therapeutics, and we will be discussing one component of therapeutics which is sometimes very complicated, and that is anticoagulation. So the first speaker is Dr. Aman Gupta. Aman is a product of PGI. He did his MD and then he did his DM in pediatric rheumatology from here. And he is based at Chandigarh. Aman.
Good evening, everyone, and welcome to this part of the session where we will be discussing about the anticoagulation in children with Kawasaki disease and coronary artery abnormalities. I'll be predominantly speaking on low molecular weight heparin vis-a-vis warfarin and other direct oral anticoagulants. So first of all, a brief review about what is the need for anticoagulation and the natural history of coronary artery abnormalities. So the coronary artery abnormalities in Kawasaki disease, they start with dilated vessels. The normal vascular tissue is damaged by the panvasculitis in coronary artery. The coronary artery is then expanded by its internal pressure, resulting in the formation of dilatation and aneurysms. So over a period of time, these aneurysms may persist, which over time can develop thrombus formation. They can be occlusion, resulting in formation, ischemia and infarction. And in some cases, due to intimal proliferation, the vascular diameter may become normal. So an interplay of endothelial injury, hypercoagulability, and abnormal blood flow results in the formation of thrombosis. In patients with large coronary artery abnormalities, there is a risk for luminal thrombosis in both acute as well as the chronic phase of Kawasaki disease. So, according to the American Heart Association update on the management of Kawasaki disease 2024 guidelines, during the acute phase, patients with rapidly expanding coronary aneurysms with Z-scores more than 10, systemic anticoagulation with low molecular weight heparin or warfarin in addition to low-dose aspirin is usually reasonable. But the damage is not limited to the acute event. There is a long-term risk of myocardial ischemia because of the various factors that we have already discussed. So, the long-term thromboprophylaxis is indicated with either warfarin, low molecular weight heparin, or direct oral anticoagulants in patients with giant aneurysms, either current or persistent. So how are these recommendations different from those that were there in 2017? The latest 2024 guidelines say that systemic anticoagulation may be considered in patients with giant aneurysms that have regressed to medium aneurysms and may be at risk of thrombosis. The lumen of the vessel may become normal because of thrombosis, in which case anticoagulation is required. So this is the difference between the AHA guidelines between 2017 and 2024 with respect to anticoagulation. So coming on to the choice of anticoagulation, there are no specific recommendations for the use of anticoagulation in clinical applications. Because there are no randomized controlled trials, warfarin till date is the most widely used anticoagulant, and there have been several studies indicating the beneficial effect of warfarin in addition to aspirin versus aspirin alone in children with giant aneurysms associated with coronary artery abnormalities. But a recent international survey, recent international survey, the choice of anticoagulation was most often warfarin, followed by low molecular weight heparin. Warfarin was used more frequently than low molecular weight heparin, both in infants as well as in older children. So despite achieving optimal control of INR levels, some case reports have indicated a risk of thrombotic events. Warfarin inhibits matrix gamma carboxyglutamate protein, which regulates calcium phosphate levels in tissues, thereby predisposing patients to vascular wall calcifications. Also, there have been several animal studies which show that warfarin induces endothelial calcification. Recent studies have also shown a proportion of patients with childhood Kawasaki disease experience coronary artery dilatation in adulthood when using warfarin as a long-term management strategy. So, low molecular weight heparin may be considered for chronic thromboprophylaxis in patients with giant coronary artery aneurysms, particularly for young infants or those with expanding aneurysms early in the course of their illness, or as bridging for patients between unfractionated heparin and warfarin. The mechanism of action being potentiating the inhibition of factors 12A, 11A, 10A, 9A, 2A by antithrombin. In a retrospective review of KD patients at the Hospital for Sick Children, Toronto, 38 patients out of a total of approximately 1,300 patients received systemic anticoagulation. 25 of these patients received low molecular weight heparin, while 13 received warfarin from the onset. So what it showed was the frequency of thrombotic events was similar in both these groups. Severe bleeding was more frequent in patients on warfarin compared to those who were on low molecular weight heparin. Patients on warfarin were at greater risk of under anticoagulation or over anticoagulation than patients on low molecular weight heparin. The maximum coronary artery aneurysm Z scores diminished with time for patients on low molecular weight heparin, but not significantly for those on warfarin. So, heparin is a potentially viable alternative for children, especially the younger ones, with coronary artery abnormality, especially the giant aneurysms associated with Kawasaki disease. In another pragmatic registry trial, to determine the effectiveness of low molecular weight heparin or warfarin for thromboprophylaxis in coronary artery abnormalities, 383 patients were studied. This graph shows the cumulative incidence of coronary artery thrombosis in patients without previous thrombosis, that is primary prevention, comparing low molecular weight heparin, warfarin, and those who had no anticoagulation. So it clearly shows that patients who had not received any anticoagulation had higher incidence of thrombosis compared to those who have received anticoagulation. Also, the cumulative incidence of coronary artery thrombosis at approximately two and a half years of starting thromboprophylaxis was similar, with no difference between low molecular weight heparin and warfarin. 63 patients developed coronary artery thrombosis as a complication of their abnormalities, out of which 51 patients received secondary thromboprophylaxis, 21 low molecular weight heparin, and 24 received warfarin. So there was no major or statistically significant difference in the incidence of further coronary artery thrombosis between these two strategies. Also, the severe bleeding complications were generally rare and noted equally for patients on low molecular weight heparin and warfarin. There have been several case reports documenting the use of low molecular weight heparin in children with Kawasaki disease associated coronary artery abnormalities, wherein they have shown that heparin effectively prevented luminal proliferation and thrombus formation in the coronary artery abnormalities. In this recent study, where the effect of deltaperin was investigated in the initial treatment phase to be associated with a lower prevalence of coronary artery lesions in patients with acute Kawasaki disease. Patients were given deltaperin along with IVIG in one group, while the other group received only deltaperin and aspirin. So it showed that the incidence of cardiac sequelae was 0% in the group who had received deltaperin in addition to IVIG, compared to around 12% in patients who had received only IVIG at a rate of 400 mg per kg per day for 5 days, compared to 2.5% in patients on IVIG at 2 gram per kg per day. So, the concomitant administration of deltaperin was associated with a lower prevalence of coronary artery lesion in children with Kawasaki disease. However, this study only showed the reduction in the risk of developing coronary artery lesions, but further studies are required to establish its effectiveness as a long-term thromboprophylactic agent. So, low molecular weight heparin can be given 12 hourly subcutaneously. The dose range from 1 mg to 1.5 mg per kg per dose, depending upon the weight of the child, age of the child, and the dose is usually titrated to anti-factor 10A target range. So I would conclude by saying that though warfarin is efficacious and is generally efficacy in treating complications associated with coronary artery abnormalities, but bleeding complications and ease of administration are the concerns. It is difficult to use in young children because of need for monitoring INR levels. It is difficult to manage in many children with INR in goal range seen in only two-thirds of the time. Although twice daily administration with low molecular weight heparin is a concern, but it has found to be equally efficacious in preventing thrombotic events. So it is preferable in infants and younger children. So my next colleagues will be discussing about the role of warfarin and direct oral anticoagulants in these children. Thank you so much.
The next speaker is Dr. Avinash Anantraj. Avinash is an associate professor in the Department of Cardiology at the Jipmer Polytechnic.
So, good evening, everyone. I thank the organizers for the kind opportunity. So, my role would be to talk on direct-acting oral anticoagulants in Kawasaki disease. So, I bring greetings from Pondicherry. So, disclaimer is I don't have personal experience in treating children with DOACs, and this is fully a theoretical talk. So, we'll go through this talk in the following contents. So, what is the need for direct-acting oral anticoagulants in children in Kawasaki disease, and what are the problems with the current standard of care, and what is the journey of DOACs in children, and what is the specific evidence in KD, and what are the disadvantages of using DOACs, what are the cost comparisons pertaining to our country, and in case we choose to use DOACs, then what is a guide that is available to choose the dose in children, and what happens if a child starts bleeding while on DOAC, what will be our strategy. So DOACs are of two types, either factor 2A antagonists like dabigatran or direct 10A antagonists, which are rivaroxaban, apixaban, edoxaban and betrixaban. So presently rivaroxaban, apixaban and edoxaban are available, so we will be restricting the discussion only to these 10A agents. So what is the specific need for DOACs in children? That is, what are the problems with the present standard of care, what are the problems with vitamin K antagonists, and what are the problems with low molecular weight heparin. So first, vitamin K antagonists, there is a need for periodic monitoring, and so periodic monitoring involves pokes to the child, which is not taken well by the parents as well as the child, and there is a need for periodic physician consult for dose tailoring, which is also a time-taking prospect for the physician as well as the patient. And significant interactions with food and drugs when it comes to warfarin. And there are significant problems with angiogenesis, and bone density impairment is a problem that has been well established with children on long-term warfarin. And also there is a problem of delayed onset of action. We start warfarin and wait for the therapeutic action to happen over several days. And warfarin has a narrow therapeutic index, as we all know. Some children don't attain the therapeutic range, and we increase the dose, suddenly the INR goes to very high levels. So there is an unpredictable pharmacological response. And studies have shown, as the previous speaker mentioned, the time in therapeutic range when a child is on warfarin is nearly only 60%. So in considerable time, the child is actually less than the therapeutic range. So there is a high chance for formation of thrombus while on warfarin. Now the problems with low molecular weight heparin, there is a need for twice daily injections, which is really a troublesome prospect for the child. And there was a study which assessed the quality of life and the parent anxiety levels when home administration of low molecular weight heparin was done in assessment in Australia. So there was a significant component of parent anxiety, and that also puts off the parents from taking twice daily heparin to the child. And it is an expensive prospect compared to DOACs in India. In the West, DOACs are more costlier compared to low molecular weight heparin, whereas in our country it is it's reverse. And unfractionated heparin has significant problems with bone density impairment similar to vitamin K antagonist. And low molecular weight heparin is plus minus. It may cause bone density impairment. So these are the problems with the current standard of care. So with the direct oral anticoagulants, there are certain pros and certain cons. The pros are it's fully administered orally, and there is no need for frequent monitoring. There are child-friendly formulations available in the West, and soon it may be available in India also. And in comparison to warfarin, the onset is immediate and the offset of action is also immediate. And there are very few food and drug interactions. There are interactions, but they are very few. And the presently available pharmacokinetic and pharmacodynamic studies, which are very less in children, show presently a stable PK and PD data. And so far, adult studies have shown that there is no bone density impairment with all the drugs that have been studied. And the little data that is available on children also shows there is a little bone density impairment. But the cons are, these are expensive. And in case a monitoring test is required, supposing there is a dosing problem or a child starts bleeding, then the suitable monitoring tests are very few and they are not easily available when it is required. And most of the DOACs, it is a twice daily administration, which is also difficult for compliance in a pediatric population, except for edoxaban. And in case of a toxicity or a bleed, when we need to reverse it, the access to the reversal agent may not be easily possible. So far, what has been the journey of DOACs in children? The US FDA approved DOACs for use in adults in 2008 for non-valvular AF and venous thromboembolism therapy. Since then, pediatricians have started using this in children for venous thromboembolism therapy and prophylaxis off-label. And US FDA approved DOACs in children in 2022, and trials for venous thromboembolism prophylaxis and treatment primarily in children who have blood leukemias and indwelling catheters have been done. And select high groups requiring treatment for, so these are all venous thromboembolism therapies. So our primary concern is arterial thrombosis. So whether there are studies on DOACs for that. So select high groups which require treatment for arterial thrombosis are KD and children who have undergone therapy for single ventricle like Fontan pathway. So there are studies on that. And saxophone, which is a study on apixaban, and N-Noble, which is a study on edoxaban, have a considerable population of KD in their study subgroup. And the present pharmacokinetic and pharmacodynamic data which are available from these studies presently show a good safety profile, and dose adjustment data for children in bigger studies are awaited. So the specific evidence in heart disease but not Kawasaki disease is available from Universe study, which used a liquid formulation of rivaroxaban in comparison with aspirin in post-Fontan children within 4 months of surgery. So usual recommendation post-Fontan children after 3 months is either warfarin or aspirin. So in comparing with aspirin, what is the role of rivaroxaban was studied in the Universe study. And they did an initial pilot study where 12 children were given the dose equivalent of 10 mg adult thromboprophylaxis dose. And after this was done, they took to the second part of the study where 100 children were randomized 2:1 to rivaroxaban versus aspirin, 5 mg per kg per day, and it was evaluated over a period of 12 months. So one child in the rivaroxaban group had a major bleed versus 0 children in the aspirin group. And there were no clinically relevant non-major bleeding events. So no significant difference was seen between the two groups. So this gave a go-ahead for rivaroxaban in heart disease. And DOACs, what are the specific evidences in KD? So N-Noble, which studied edoxaban versus standard of care. So 100 children, this is also a 2:1 comparison. So edoxaban versus standard of care, either warfarin or low molecular heparin. Of the 100 children in edoxaban group, 24 were KD. So almost 1/4 were KD. And in 22% of the standard of care group also were KD. So overall 22% were KD children. And in the saxophone study, that is apixaban, there were 3 categories of children. So there was a question regarding like what is the age from which DOACs have to be used. In both N-Noble as well as saxophone, in saxophone beyond 28 days. So newborns were excluded, but from 1 month of life, there is data for use in children. So till 18 years were enrolled in Ennoble. So we can practically take from 0 to 18 years, there is data for DOACs. That is these two DOACs which were tested in KD. So in saxophone, KD population comprised of around 14% of the study group. So in Ennoble, as we can see from the table, there were no significant differences between the standard of care and edoxaban. And in the saxophone study also, there were no major differences. So in both the studies, it was found that the DOACs were comparable to the standard of care, or in other words, non-inferior to the standard of care. Now, dabigatran, diversity was a study which was not related to patients with cardiac disease, but children at risk of venous thromboembolism. So this was done even prior to the studies which we discussed previously. So from 2014 to 19, and a longer period, and 2:1 randomization, dabigatran versus standard of care. Non-inferiority design was done, and this was also from birth to 18 years. So patients received various formulations based on their age category. And there were 5 minor bleeding events and 1 major bleeding event in the trial group. And P for non-inferiority was achieved, and there was no difficulty in compliance. So that was also assessed. So in the various formulations that were given to the children, there was no difficulty in compliance irrespective of the age. So what are the dosing studies which are available and how to choose the right dose? So apixaban, the data from saxophone, like how they used based on the weight, what dose was used is given here. And what formulation, whether a liquid formulation or a capsule or a tablet was given. And these are the dosing studies from rivaroxaban. So rivaroxaban, in Einstein junior study, it was used for venous thromboembolism prophylaxis. So this was not a cardiac population. This was a general population, like children with tumors and other children at risk of venous thromboembolism were treated here. Whereas Universe study was the post-quantum thromboprophylaxis, where aspirin was compared with the 10 mg equivalent. So in Einstein, 20 mg equivalent of the adult dose was given, which was a BTE treatment, whereas in Universe, 10 mg equivalent of adult dose was given. So that was the thromboprophylaxis dose. So the doses which are used for rivaroxaban are available in this table. So in the diversity study, dabigatran, as we previously saw, various formulations were available based on the age ranges, and what were the doses which were used is given here. So how to choose the right dose for edoxaban? In the Ennoble study, edoxaban was used like this, like 1.4 milligram per kg until the age of 6 years, and 1.2 milligram per kg for the age of 6 to less than 12 years, for a maximum dose of 45 milligram. And beyond 60 kg, the adult dose of 60 mg was used. So now cost comparison, whether it is viable to use in India. So I have taken the prices from NetMeds and the select brands which are usually available. So apixaban, a strip of 10 costs around 3,200 per month, and warfarin costs around 100 per month. So this is a cost comparison. Low molecular weight heparin, if we are giving twice daily for a 40 kg child, it costs around 28,000. So Western data says DOACs are costlier compared to low molecular weight heparin, but in our country, DOACs are still cheaper compared to low molecular weight heparin. Thus, apixaban is 40 times costlier than warfarin, whereas low molecular weight heparin is 10 times costlier than apixaban. And rivaroxaban is cheaper than apixaban, whereas dabigatran is like 10 tabs cost around 720. So DOACs are costlier compared to oral anticoagulants, but cheaper compared to low molecular weight heparin. And child-friendly formulations, dabigatran comes as sprinkles or pellets in various strengths and as an oral formulation. But this is all data from the West. In our country, we are able to see that only the adult formulations are available. So they have to be converted into solutions, which we usually do for pediatric population in the other drugs. And edoxaban is available that can be crushed into liquid for younger patients. So tests to assess the anticoagulant effect for dabigatran, APTT, TCT and dilute TCT are used. And for anti-10A agents, anti-factor 10A assay is used, and PT-INR shows a minimal effect. So what are the antidotes in case one is needed? So for dabigatran, idarucimab is used, whereas for factor 10A agents, it is andinoxidant alpha. So what are the adverse drug effects of direct anticoagulants? So for bone metabolism, heparin is bad, low molecular heparin probably neutral, vitamin K antagonists are bad, whereas DOACs appear to be good so far from all the adult data which is available here. So all these are adult data, primarily for rivaroxaban and edoxaban and dabigatran. For saxophone, pediatric bone metabolism data was studied, but it was a very small number. So paired bone density scans were available for 16 participants on apixaban and 11 participants receiving standard of care. So the mean change in lumbar spine values, so here also Z-score was used. So they found that it was minus 0.2 to minus 0.3 for standard of care agents, whereas it was in the plus Z-score for apixaban. So they could not reach a meaningful conclusion, but they suggested that the negative Z-score in the standard of care arm suggested that the possibility of either less bone accrual in the pediatric population taking standard of care. So we may come to a conclusion that saxophone is probably better compared to standard of care when it compares to bone metabolism data in pediatrics. Heavy menstrual bleed, especially in young adolescents who are on oral anticoagulants, was a problem which was encountered in Hokusai VTE data, which was a study on VTE in children taking direct A antagonists. The characteristic and outcome of abnormal vaginal bleed in women who are less than 50 years of age receiving edoxaban or warfarin for the treatment of VTE was studied. And abnormal bleed occurred more frequently in women treated with edoxaban rather than warfarin. But most of the events could be conservatively managed, and it was only a mild outcome. So we come to a scenario where a child on DOAC needs urgent surgical procedure. So the recommendations that are given are, in case of a low bleeding risk procedure, stop the DOAC 24 hours before the surgery and restart on the same day if there is no bleeding. Whereas if it is a high bleeding risk procedure, stop 48 hours prior to the procedure and then restart 24 hours after the surgery if there is no bleeding. And what to do if a child starts developing bleeding on DOAC's treatment. So there are some case reports which are available. So what have been done in these case reports? So a child who developed an intracranial hemorrhage while on rivaroxaban, a child weighing 20 kilogram, from the adult data which is available, they had made a dose extrapolation, and they had made a 25% of the adult dose based on the weight of 80 kg, assuming an average adult will be 80 kg. So they had given 100 mg of IV bolus of andinoxant alpha, followed by 100 mg IV infusion over 100 minutes. And with that, the child improved, and she was, burhole was done, and the ICH was relieved. And dabigatran overdose with a poisoning intent was taken by a child who was 15 years old, and edorizumab was used for reversal. So here they were able to show the test data also. So they were not able to get the drug initially for the first 20 hours. So initially they managed with other drugs. So the APTT data and the thrombin time data, everything is shown. It is all deranged till the first, till the time the edorizumab was given. And within 1 hour of giving edorizumab, it has come to the normal range. So probably it is reliable for dabigatran in children also. So summarizing, almost 2,800 children aged less than 18 years have participated in the various direct oral anticoagulant studies, providing evidence on safety and efficacy in the pediatric population. And they have almost similar efficacy and safety profiles compared to standard of care in the pediatric population also. And significant advantages over current anticoagulant options are available related to ease of use. And PK and PD data also derived from trials show that dosing regimens in children achieve similar drug concentration similar to adults. And results also confirm that therapeutic monitoring is not routinely required in majority of the patients receiving DOACs. So conclusions, DOACs have an undeniable advantage over VKS and LMWH, which are the present standard of care. And with specific evidence in KD, the two drugs are apixaban and edoxaban. Specific evidence in heart disease, but not KD, is rivaroxaban. Edoxaban is definitely superior because once daily dosing is preferable in children, and no safety data on reversal of agents in children is still now available, and it's still not FDA approved. They appear to be bone safe from the present data which is available, and menstrual bleeds in adolescents is a concern. If expense comes down, they will play a bigger role in India. So thank you for your kind attention, and wishing happy learning in the upcoming talks. Thank you.
Thank you, Avinash. Both the talks are now open for questions. We have never used DOACs in KD. We have been managing our patients with warfarin and low molecular weight heparin. With both of these drugs, there are issues in children, but they're manageable. They're manageable, and we've never rejected using these drugs. But of course, in the times to come, I'm sure many of us will start using DOACs in this situation. There are several large studies going on DOACs in KD, and Dr. James Burns Center is gradually shifting to DOACs. So, any questions or comments on the two talks by Dr. Aman Gupta and Dr. Avinash?
So, we have recently used drugs in two patients, but of course, central parents are disease. So, one patient was using under the cause, the MR was the MR starting was. And recently, we have a patient of nephrotic syndrome with cerebral thrombosis, but who also had factor 5 mutation. So, that patient was discharged. Initially started with MLH and discharged patient on the cause, but not the
So for last 6 months we have completely shifted to wax, but same as we are not yet sure for what will happen if the child bleeds after. So far we have not got any instance of bleeding. So for most of the cases where we were using warfarin, we have started using wax even in all the cardiac group also except for the MDR patients. But for the testing and whether it would be as efficient as warfarin, we are not yet sure.
Thank you. Murugan.
We may give FOP for such situations. It also has factor that we do need a special antidote. What's the difference between them?
Like people have used tranexamic acid and prothrombin concentrates till the time the idarizumab was available in that child, but I'm not sure about.
What's the special concern of that drug when compared to the other agents? Like warfarin is also fluoxetine, LMWH also has any activity, which gets reverted to the FOP. What's the special about these molecules? Need a specific drugs.
I'm not sure like specific agents why they are required, but
The specific antagonist.
yeah.
The specific antagonist.
And
Otherwise, the other things which are generalized treatment which you carry on in India.
And even after the agents have been given, the thrombin time was not corrected. But after the idarizumab was given, immediately it reversed to normal. So.
Sir, is the antidotes are available ready?
Yeah, it's a difficulty getting it. So even in the West, this report was from Britain. So even there, it was difficult to get within like 20 hours they took to arrange the drug. So.
And what is the half-life of the molecules or drugs? I mean, if side effect data, etc., how to manage that?
No, after giving the agent, the effect gets reversed within an hour. That's what we saw in the report. So if the specific antidotes are available, then it's getting reversed immediately. And
There are limitations in our country.
yeah, I think getting the agent, I'm not sure like whether it is easily available. I do.
Thank you, sir.
Despite the academic food restriction, we found that most of the time this INR variability from the lab to lab. And then he sometimes switched over to acid form or like that. Is there any solution for or one lab we have to rely or what is the suggestion for INR variability?
I don't know, sir. Like we have the same problem in JIPMER, not with children, but with adult patients post valve replacements. So I mean, we take our lab as reliable, but I don't know whether that is the case. But most of the time, patients get it done from outside and then they come with the reports. So it is a difficulty doing that. And presently, we have one child who is on warfarin with a giant aneurysm. But I mean, she never attained the therapeutic range. So INR is always 1.5, 1.6. We have increased it to the maximum, beyond the maximum weight also. But we are still not considering DOAC because of the cost consideration. So that is it.
You have touched one important aspect that you have never touched the therapeutic targets of the INR. So, but we have also seen and we have analyzed data, Sudhir has analyzed data on the anticoagulation in Kawasaki disease. So, what we have seen is that we may not need such a high therapeutic targets of INR in patients with Kawasaki disease always, and our therapeutic range is around 1.5 to 2. Okay. And on that, most of the patients are doing well. We are yet to finalize the final analysis, but based on that, possibly, and there are one or two studies published from James Group also, and they also suggest that possibly that more than 2 INR or that possibly is difficult to achieve also, and it may not require always. So possibly we have to maintain, and whenever we try to maintain a very strict range, because it will go beyond that, and that is also a problem in young children. So possibly we can and I don't know whether we are right or wrong, but possibly because based on our experience, around 1.5 is also reasonable.
I do agree. 1.6 to 2.2.
Sir, we usually don't require monitoring when the patients are on the wax. So, is there any particular dosing or particular age group in which we have to monitor for the side effects or to look for the risk for bleeding in particular populations?
Yeah, like from the studies which are available, no specific recommendations are there, and they are not tested in specific age groups. But because they assessed the pharmacokinetic and pharmacodynamic data, they were in their protocol, they had specific time periods at which they were doing the test to assess the drug levels and all. But as such, there is no indication to monitor the drug levels or to check the anti-10A levels.
Thank you, Vilas.
Thank you.
With this, we move on to the next talk, and that will be given by Dr. Mansoor Singhal. And for a change, we would not be talking on CT coronary angiography. He will be giving his experience with cardiac MRI in children with Kawasaki disease.
स्लाइड शो किया ये है ना दोबारा कीजिए बंद करूँ क्या इसके अब स्लाइड शो कीजिए यहाँ से आ गया ना ओके इसमें ले
Thank you, sir. Definitely, this is a change for me as well. So we will discuss, we were discussing about the role of the advanced imaging methods, especially the cardiac MR with Professor Itsuko Suda. And I had an opportunity to work with their team when I was in NCVC, and that gave us a lot of impetus to, integrate this imaging. And I'm happy to share that we have started doing MR in this thing. I will show you some examples. So if we talk of Kawasaki disease, so it is not just restricted to the coronary arteries, and it's much beyond that, which has been proven beyond doubt. So for that matter, definitely we need to see the coronary arteries and their long-term follow-up, and it involves myocardium, and recently, it can be in the form of inflammation, ischemia, or fibrosis. And yesterday I was enlightened by your talk, ma'am, that it involves endocarditis also. So we'll look into that aspect. Can we see on that on any imaging? So if we see, there is unambiguous and unequivocal concept that KD, not only just involve coronary arteries, it involves myocardium and maybe other organs which are still unknown, because that is the enigma and that makes this disease fascinating for all of us. Whether it's coronary arteries, whether it's myocardial ischemia, or whether it's how the myocardium is involved. What about the functions, valves, as far as endocarditis is concerned. But that is usually restricted in the acute phase, and the involvement of systemic arteries. So when we talk of MR, we talk of MR angiography first. You must remember that it is a high diagnostic accuracy for the coronary artery abnormalities, and at the same time, It gives us an opportunity for assessment of the function, which is the gold standard nowadays, and myocardial tissue characterization. Combining MR angiography with the cardiac MR may be a challenge and can take long acquisition times. And in most of the centers, including NCVC, they will divide this into 2 studies, but in PGI we try to club both as one. If so is the case, then why I always talk of CTCA then? Why not MR? Because it has a long acquisition times, and yesterday we were discussing with Professor Suda that majority of the children may not, are not comfortable MR doing for the next time because of long acquisition times. But having said that, this is one of the caveats of cardiac MR other than this lower spatial and temporal resolution what we get with CT. An assessment of mildly stenotic lesions and assessment of distal arteries may be difficult on MR. And there is the CTC help. So, we need to customize, tailor our investigation based on clinical need. So that is why from a general concept, the medicine is shifting more towards the personalized and precision medicine, and that's the way forward. And in diseases like AD, this becomes more imperative. So if we see, we'll go see what are the possibilities on cardiac MR. So first we need to see the coronary arteries, which can be, gives us an opportunity to assess aneurysms. Yes, we can see aneurysms, stenosis, thrombosis, occlusions, collateral flows, everything is possible on cardiac MR. We will see in some case-based approaches that we have done. These are practical things that we have been doing. On MMRCA, you can see the coronary artery anatomy if done properly and child cooperates. You can see all the coronary arteries. This is the RCA, which is showing a fusiform aneurysms. And so is the aneurysm sitting in the LCX. And you can have, 3-dimensional imaging of the MRCA that you can do with the CT scans as well. These are just, it all depends how the child had been cooperative and the imaging has been done. So when I say this, so usually MRCA should be restricted in the children who can get an MR done without any, when the child is old enough to listen to our instructions. Am I right, ma'am, Suda? For younger children, the MRCA is difficult and should not be even considered. So we have discussed about there are videos it is expected to be. Just a minute. The second part is, when we have stenotic lesions and these are on follow-up, the MR, when we talk of MR, usually it is in follow-up imaging. It is not at during the presentation or the initial presentation. So when you have stenosis, so we have seen morphologically, if there is a stenosis, what is its effect on the myocardium? That you can see either with a stress perfusion or a dobutamine additional stress. So with that, you can see what is the hemodynamic effect of those lesions, and that can help us in making therapeutic decisions, maybe in the form of interventions or in the form of surgical intervention. That depends on how many arteries and how many segments are involved. So this is about, the stress MR. So, these are the borrowed slides. So there is an aneurysm in the LAD. And if you see, this is an rest perfusion versus an stress perfusion. I don't know. It's not projecting. Can you see this black line, which is then LAD territory that tell you, this territory is ischemic. Whether this territory is infarcted or not, you can see on the late gadolinium enhancement imaging. So in that late gadolinium enhancement, anything which is white is dead. And the good part is, if we talk of the American 17 Hurt model, so the vascularity or the vascular supply is territorial. That can tell you very well which territory is involved. You can see this black line coming towards the LAD side. This tells, this territory is slightly ischemic. Now, third thing, so we have discussed two things. We have discussed the anatomy. We have discussed about the ischemia. Third thing is what is the effect of this disease per se on myocardium, and how the myocardium is getting affected by ischemia is by myocardial tissue characterization. So why this concept has come? This concept has come from Dr. Najib Dada, who had written a remarkable article who said, see, KD is not just coronary arteritis, it's probably myocarditis as well. So, over the time, as of now, I can make this statement. Myocardium may be involved in the initial phase, but the scans that we have done, maybe around 50, maybe around 85 as of now, we have not found myocardial abnormalities except in infarction. So maybe myocarditis may be an acute event which probably resolve. I don't know whether this statement is right or wrong. This statement is solely based on the imaging that we have done. And infarction we can detect up to 1 gram of tissue. It's so specific. So when we talk of myocardial tissue characterization, we has already discussed the ischemic scar always territorial. And that's how we can distinguish whether the scar that we're getting on myocardium is ischemic or was vis-a-vis it's a sequel of myocarditis that patient develops during the initial presentation. And how we do that, we'll show with an example. This was a 10-year-old male who is the daughter of a pediatrician. So, there was a thrombus in one of the proximal segment of the left can I see, let me show that, bring that pointer. Okay. There was a thrombosis in the proximal LAD, and you can see the scarring, which is transmural in the region of apex. And these, these are the recent parametric maps, these are T1 and T2. I think this is beyond the scope of discussion as of now. Just showing these images to make you aware that these things are also possible. And more important, you can see the function which is gold standard, which can help you in longitudinal follow-up as well. And the fourth thing is the ventricular wall motion and the quantifications. You can see whether it is hypokinesia, it is akinetic, it is thinned out. If it's thinned out where there is thrombus inside, so what you do is you have a stack of short axis images from base to max, and with this stack you calculate your functions based on drawing the circles on the endocardial, the epicardial. These are 4-chamber views, and this is the 2-chamber or the vertical view which you see with the and this is how, sorry why this slide has migrated. So you can have your this LV function, RA functions, RA dimensions, everything, and you can have in a single investigation. Then about the endocarditis, if there is a mitral regurgitation or mitral abnormalities on follow-up, you can see the valvular regurgitation. You can quantify them. You can see this in jet, because of mitral stenosis, you can see which is the LA is dilated as well, and you can quantify them. And this quantification is gold standard. It is just like you do on echocardiogram. In fact, better than that. And at the same time, if there is a suspicion, this is not something which is to be routinely done. If you have already diagnosed patient having systemic aneurysm, you can do an contrast enhanced MR angiograms, and you can image all the systemic arteries. This is one such example which I have taken from literature. So a cardiac MR, it can give you immense information, which is not just restricted to morphology. You can have functional information, you can have myocardial tissue characterization. And having said that, it is the only investigation that can tell you about myocardium. There is no investigation as of now which can give you the insights in myocardium other than MR. Now, what are the newer updates? This I learned when I visited Dr. Suda's center. So you can see the intraluminal or the mural pathology, intraluminal morphology, and when we say the MR is a long acquisition times, now there are a few things in place which we call as compressed sensing that gives acceleration to image, and we can cut short imaging times. We have yet to see it. So once we have done the morphological imaging, this is called a Dixon scan. I think you must remember this word, Dixon image. With a single acquisition, it gives you 4 set of images, and this 4 images is fat, water, and fat is in phase and out phase, with which you can characterize your plaques. You characterize your thrombus, and this helps in follow-up. So this is an image from your center. I forget his name, who is an MR radiologist. Dr. Moita, yes. So, so this is in CTCA, you see calcification. Calcification is a killer for the MR investigation. So this is probably one of the investigation at the beginning, and you see you can do an heavily T2-weighted MP range images. In that you can qualify the lumen as well. In other example, you see this is calcified lumen, which is thrombosed, and you can see on follow-up with some bright dots between showing areas of recanalization. And with this, there has been change. And this has been made possible because this is slightly busy slide and more directed toward radiologists. But I want you to know this, how this is possible. This is possible, and you don't need any contrast. And these are inverse recovery based sequences which are heavily T1 weighted. That gives you about the vessel wall information. Now this is one of the slides I requested Professor Utsuko Suzuki ma'am around many years back, and she was kind enough to share these slides with me. So I am thankful to her. The MR is a major role when you have a thrombotic lesion. So there is no way we can follow them up. So what she showed me is an echo image. This is an echo image which is showing thrombus, and this is a catheter angiogram, large aneurysm which are born from thrombus. On MR, you see this large thrombus, and when you do perpendicular imaging to it, you will find something like cobweb type of appearance, and this is the morphological images of the same. So MR not only will tell you the morphology, it helps in characterizing the plaques as well as the vessel wall. But this is what it is. But what is the CMR in the real world scenario? The real world scenario is at presentation, it is not advisable or indicated. And follow-up, definitely it has a role. And what's the role it has? It's a long-term management of sequelae of KD, which may be in the form of coronary artery abnormalities, thrombosis, and you can have functional information and myocardial tissue characterization, and which are indispensable. So I will show you a few examples which I have done very recently in the last 2 months. So this is one example. I think Dr. Yamini is going to show these cases in details maybe tomorrow. So this was an 8-year-old child who was diagnosed with Kawasaki disease, and these are CTCA images at presentation. So you see there's complex aneurysms in the proximal LAD, which is involving the diagonal 1 images. LCX is involved, OM is involved, RC is involved. On chloride inspection, I think RIPU is presenting this case. If you see the proximal RCA is dilated, and you see a filling defect in the mid RCA which was thrombosed. Now we have an option to image this patient on CTCA, but matter of the fact is these patients will have many follow-up examination. Is it justified to put this patient on ionizing radiation every time? So we have selected these patients, and Rakesh is a part of that team. So what we have done MRCA just 2 weeks before, and this is a follow-up of MR after 3 years. And what you see over here is, I will show this video as well. You can just have, wonderful imaging, and you have seen that RCA aneurysm is more or less regressed and restricted only to the proximal segment, and this aneurysm is also remodeled. And probably there is a tight stenosis at the, the LAD. So probably we'll do an functional imaging as well. The function was more or less normal in this patient. So this is about the function. So we have got morphological information, we have got functional information. Then you can have the perfusion imaging. This is the first pass perfusion imaging, which is a standard for any MR protocol. Ma'am Suda, we are not doing stress MR as of now because of our own restrictions and challenges. This is the LG images which shows the myocardium clean, no thrombus. LG, you see there is a bright spot. Can you see this? Can you see this bright spot? This is subendocardial, this is inferior wall MI. So means what has happened is this thrombus which has happened in the mid RCA has led to a small volume thrombus through small volume MR infarction. And this is very, very specific. It is 100% specific. That is territorial, but it's subendocardial. It is not transmural. So it will not have any, we know that, it has caused some defect, but it is not that functionally important. And there are advanced parametric maps that we do on T1, T2 images to see the myocardium elsewhere where the LG is normal. And with this, we do multiple ROIs, and till yet all the patients, we have found the T1 and T2 values within normal limits. That is, very satisfying to me that probably myocardium may be involved in the acute phase, but definitely it heals over or get unaffected in the chronic phase. I will show you the second case. This was a child who had a very relentless, and very, scary clinical presentation. Pleuropericardial effusion. All the coronary arteries are badly affected, so much so that pericardial window had to be created. And this is now this child is 22 years old. I think he's an athlete now. Rakesh is an athlete now. Huh? This is, he's playing very well. So this is an MR that we did 2 months back. So what you see over here is most of the aneurysm have regressed, and this is the LAD aneurysm is also regressed, and more importantly, there is no stenosis. So beautifully it will tell you about if had there been stenosis or it is a normal vessel. Functional global LV assessment was perfect. His ejection fraction, if you see, was more than 60%. You see it's 61%. And these are their MRCR images, myocardial perfusion imaging, no perfusion defects, no LG. This is very, very satisfying, though patient has coronary artery abnormalities, but it has no impact down the line into the myocardium. So we can tell them to have his normal activities done, but definitely to continue on medications and have follow-up imaging. And tissue characterization, what we have discussed on T1 and T2 maps were within normal limits. So with this, though we have discussed all the aspects of MR, we have some practical implications that we have seen, and I would like to conclude what I have learned from the giant sitting in this hall, that MRCA gives you an explicit demonstration of coronary artery anatomy with plaque characterization and so. For that, it is the investigation of choice, probably for the thrombosed patients. And we need to know which imaging and when that imaging has to be done. So it is recommended only in follow-up of patients with large aneurysms or aneurysm with thrombosis. Perfusion imaging, rest and stress, you can consider. Rest is a part of investigation, whether patient need to be stressed depending on whether the patient has stenotic lesion or not. If there is stenotic lesion, then either you can have in cardiac MR or have a nuclear myocardial perfusion imaging. But nuclear myocardial perfusion, remember, it associated with large radiation exposure. The myocardial tissue characterization that you get is highly specific, and the addition of parametric maps will tell you about the areas of the remote myocardium where the LG is not seen. Acute phase, definitely childs are small, it is not recommended, and if at all you have to consider you need general anesthesia, so it is not recommended. And we need to know, there may be investigation, but we need to know what they are, what they offer, and what are the challenges. So challenges are long acquisition times, and definitely the expertise. Still we are struggling for the last 5 years to make this MR a reality the way it should be, but days are not very far that we'll achieve that day once. So we are rigorously, pursuing that MRCA, and we are very happy and satisfied with the progress made so far. So with this, I conclude, and I would like to have the questions, which I believe should be many. Thank you.
For the poor pediatrician, life has become very complicated. We had echocardiography before, that was followed by CT coronary angiography, and now we have the full gamut of MR angiography. Questions? Yamini, Lutu?
So thank you for such a wonderful presentation, and it was so eye-pleasing. So my question is, like we know, it is very rare to have progressive increase in the giant coronary aneurysm in the chronic or the remote phase of KD. So what is your experience about progressive increase in the size of giant coronary aneurysm in the remote phase. Also the development of new aneurysm in the remote phase.
There may be, Madam Sudha, we can help me as well. Ma'am, she is asking what is, can the aneurysm increase in size over time or can new aneurysms can develop? So this is just an observation we have seen in few patients and the aneurysm we have seen increasing in size, the new aneurysms coming up.
We experience 5% of patient coronary artery red carrier directed and expanding and was found. But expanding addresses adult was found. And but in such case, harsh case increase. But in one case, in giant damage, those occur and the root of coronary artery was low, almost lower. But difference, some cases, more and more expanding, rejection of values and coronary artery virus grafting was performed report.
I mean, they can expand in 5% of patients. We have just seen few and has an experience of more than 3 decades. Yes, that is not unfortunately. Yes, ma'am. It's always, delighting to answer your questions.
Thank you so much for this wonderful presentation. But just I was wondering, what is your experience with the late gadolinium enhancement later on when you follow up the patients?
We have done maybe around 80-85 patients. It's a wonderful investigation.
So, you're not finding many
No.
positive
I
cases?
only found the late gadolinium enhancement only in the patient who had giant aneurysm and probably thrombosis. Otherwise, we have not found LG in any of the patients. What to talk of LG in parametric maps had only been normal.
Another thing is that in MRI, can we see the inside of the coronaries?
Yes.
We can see the
That's why
inside of the coronaries as well.
That is why the Dixon imaging, that you can get it, you can characterize the inlumen contents, you can see the intra-plaque hemorrhages as well, you can see calcifications, you can have serial monitoring of the thrombus.
I noticed there was a case where you had a child later grown into a 22-year-old adult who had an aneurysm and he's an athlete now. So if we are not doing the MRI and not checking the lumen, how safe are we to give them this kind of a go-ahead that they can do the usual athletic activities?
Yesterday also, probably missed, we had 3 patients when Madam had seen. So one of them is an archer, this was a different patient. He had an aneurysm. So conclusion was, if this aneurysm, patient has to continue on therapy. Patient need to know its thresholds and he should not continue beyond one threshold, and Rakesh can answer it better about the counseling and everything.
This is with the MRI or without the MRI?
Until, once you have a stenotic lesion, he has to undergo myocardial perfusion. You lost one child just now, around 3 months back. He was a mountaineer and he kept on, climbing and he collapsed. So you must, when you have a stenotic lesion, that's how, you do the molecular
What I'm saying is, suppose you don't have a stenotic lesion in echo or CT also.
Yes.
you don't have a stenostic lesion.
No need, no need.
If it regresses, then can we give them the go-ahead that they
Yes,
can do?
yes, yes. That's what Madam
checking
Sudha
the
has.
luminance.
Yes, yes.
Then
That
also-
Madam Sudha can also answer that question. And he is asking if there is no stenosis and the lesions are there may be lesions. Can the child go ahead with his normal physical activities?
No stenosis. In the case, if no stenosis, not limited for activity, I do it.
Rakesh can answer in our setup.
Thank you for the lovely talk. Sir, I have just one question. As you said that there is a lot of problem because the time restriction is too large in smaller babies. So sometimes we only need to have or follow functional assessment of the ventricles. So with the new high-end echo machines, which give functional assessment, the 4D functional assessment as well as the myocardial work, how closely do they relate to the MR?
So there are, one is theoretical part of it, one is the practical part of it. The gold standard is MR, no ambiguity about that. But why we need myocardial function in every patient who is in KD? Echo is good enough. When we do an MR, we don't do for function. When we see there's an abnormalities and part of that investigation, but not in every part. That's why in the beginning I said angiography as well myocardial function are two different subjects. And in every center, they will do as two separate examinations. We need to know what is the purpose of doing an MR, whether you want to see the coronaries or you want to see the function. And function is only to be seen when there is stenosis. When stenosis, you do perfusion, stress as well as rest, and you see the myocardial, what is the end effect within function. In any case, what I mean, it is not just a protein thing that it is all realized. Every patient is different. Every patient across for any disease is different. You have to customize, you have to individualize. The guidelines is just an umbrella, but you have to, you have to think which investigation is to be done in which clinical situation.
So I have a question. So when we are following patients up chronically, there might be a dilemma that if the aneurysm is regressing or a stenosis is developing, like it might be reducing in size. So is that just the regular course of the disease where the aneurysm is just regressing or the artery is undergoing stenosis? So can we be assured that if we do a cardiac MRI with stress testing, it will help to solve this dilemma? Can we use this?
Yes, definitely, it is a way forward. If there is a slight clinch of the diagnosis, or if you think over it, if there is a stenosis, you must consider myocardial perfusion imaging, which can either be in the form of MR or nuclear myocardial perfusion imaging. In NCVC, if they do a lot of myocardial perfusion imaging, which is radiation optimized. And I checked whether we have that system, and we have that system. The semiconductor based system, and we have one system.
Sir, one practical question.
Yes.
So do you use general anesthesia for operating this MRI?
No, it should, if you have to consider anesthesia, don't consider MR. As simple as that. We get a lot of respect for congenital heart disease. We straight say no. If you want to have anatomical information, go with CT. If you want to have some functional information, consider echo. That's it.
Okay, thank you.
Thank you, sir. Thank you so much. I would like to make the emotional statement coming to this forum. I enjoy being an pediatrician rather than a radiologist, and I cherish it. Thank you so much.
So we go on to the next talk, and this will be given by Dr. Pankaj Gupta, who is an additional professor in the